away than the general population. So some smoke more heavily when they get the opportunity, when they have cigarettes. They'll share the same cigarette with friends or strangers, and they'll pick up other people's discarded cigarettes and smoke them. Or they'll pick up the discarded cigarettes, empty the remaining tobacco out of them, and remake a new cigarette with a new Rizla paper. And we've known this for a long time, but the awareness of this and mostly around with people who are homeless and people who work with them has been a lot greater since COVID struck, because most of these risky behaviours was a transmission route to getting COVID or other infectious diseases. And this group also has additional challenges to contend with. So this data comes from Southwark, where I work. That's the borough that I work in. And nearly half of people who are rough sleeping in Southwark have a mental health condition, and 37% use illicit drugs, and 28% of them also have an alcohol condition. And that's a bit of a problem. The high smoking rates are a bit of a problem, because in the UK, about 200 people a day from the wider general population die from a smoking related condition. And for context, around 25 people a day, again across the wider general population, from the alcohol use, and 8 people die a day from their drug use. So that's too many deaths a day, but you can see the differences, the vast differences between those who are dying from a smoking related condition to an alcohol and other substance use related condition. And for a number of years now, the advice from several organisations such as the Royal College of Physicians and Public Health England and Cancer Research UK is for smokers who are unable to quit or don't want to give up nicotine completely, is to switch to cleaner forms of nicotine. So going from the most harmful way to get your nicotine, which is in a combustible tobacco cigarette, to the least harmful way relative to smoking, which is nicotine replacement therapy or e-cigarettes. And many countries and organisations now are working towards achieving a smoking prevalence of 5% or less within the next decade. And in this country, the government's ambition is to be smoke-free, which is not quite smoke-free, but a prevalence of 5% or less by 2030. And at 5% prevalence, there'll certainly be fewer people who smoke across the world, but that's still millions of smokers, given that 1 billion people around the world smoke. And we've known for a lot of years since these ambitions have been published that we know who that 5% will be left smoking. It will be people from lower and middle income countries, but it'll be people in our mental health services, in our substance use services, and across the homeless sector. So we need to consider how realistic is it for smoking prevalence to reduce to 5% or less in this population within the next few years. So we wanted to give you an overview of recent research that we do to try and address this problem. And this was a study that Sharon led on a few years ago. It was a survey of just over 200 homeless adults in Kent and London and in Edinburgh. And 90% of them shared the same cigarette with other people. 15% admitted to smoking discarded cigarettes, but we think that probably would be much more, but there's a lot of shame associated with smoking discarded cigarettes. And remarkably, 3/4 of them said they wanted to quit smoking at some point in the future, and 9% of them had tried to stop in the previous month. And 77% of them said they were interested in trying an e-cigarette, but they were limited by their income. They said they could afford about £5 to £10 for an e-cigarette. And off the back of that survey, we applied to the NIHR for some money, and it was a collaboration between several universities and homeless charities. And we conducted a feasibility study to explore how well the uptake would be of providing people with e-cigarette starter kits versus usual care. And we did this in 8 residential and day services for people experiencing homelessness. And in 4 centres, staff got usual care. So staff gave clients a leaflet and signposted them to the local Stop Smoking service. And then we compared that with 4 centres where staff gave out a free e-cigarette starter kit, and it was one of these kind of devices where you recharge and refill them with e-liquid. And we give people a 4-week supply of e-liquid and then a leaflet as well. And in terms of the feasibility outcomes, over a 5-month period, there was about 153 people eligible to take part, and we managed to recruit 80 people in those 5 months. And 42 of them received the e-cigarette intervention, and 21% of them quit after 4 weeks, and 32 people received the usual care intervention, and nobody quit after 4 weeks. And half of them we retained half of them within the study at 6 months later. And we found that their anxiety and depression scores and their audit scores declined as a whole over the 6 months. And then a couple of pieces of research we did during the pandemic. So Cancer Research UK funded a study of a survey of 99 homeless services throughout the UK. And we found that 11% of homeless services had an on-site stop smoking support service. And sometimes that was in reach from the local stop smoking service or people trained in smoking cessation. 35% of the 99 services referred people to the local stop smoking service but had no links with them, and 12% referred to services and had an established relationship with them, and 1% had established links with their local vape shop. And what we also found was that the majority of respondents to the survey said that staff smoked with service users within the centre. And the biggest problem they faced, it wasn't the health effects of smoking. Staff reported that cigarette litter and complaints from neighbours was their biggest problem. And also half of respondents reported that there was disagreements between staff and service users about their smoking quite regularly. But there was this willingness to do something differently. And we also did some work with rough sleepers in London as part of the Everyone In project. So within London, around 5,000 people have been accommodated in 14 hotels. And I worked as part of a Pan-London homeless drug and alcohol service, a brand new service funded by Public Health England and the Greater London Authority. And as it was rapidly set up, the psychiatrists who were leading this service clinically made sure that tobacco harm reduction support was in place from the outset. So what we did was we supplied all the London hotels, and we still are supplying those. I think there's 4 still open at the moment. We supplied them with e-cigarette starter kits, and this was closed systems. So these types of e-cigarettes and refills. We also supplied them with nicotine mouth pouches and gum and sprays. And we didn't do this to kind of get everyone to stop smoking. We did it to minimise the risky smoking behaviours. So we did it to minimise congregating outside hotels to smoke and sharing cigarettes and smoking discarded cigarettes at the height of the pandemic. We also wanted to reduce nicotine withdrawal symptoms if people were confined to their bedrooms. We wanted to reduce the risk of fires from smoking in bedrooms. And we also wanted to try and reduce the risk of eviction from the hotels because of their smoking behaviours in bedrooms. And at the beginning of the pandemic, and this wasn't universal, it seemed to be restricted to certain charities that were running the hotels. They were evicting people because of their smoking. And if there were any former smokers, we wanted to prevent them relapsing back to smoking. And colleagues at King's, Joe Neal and colleagues, they've done a longitudinal qualitative evaluation of residents that were in one of the hotels. And we also did some qualitative work of staff and residents throughout all the hotels. And for the hotel residents, what they said was, in terms of the treatment, the tobacco harm reduction outcomes that mattered most to them was not having the shame and the indignity of smoking other people's discarded cigarettes. So one chap who was from Italy and had no recourse to public funds, he said he didn't need to wear any more when it rained, because obviously when it rains you don't get dog ends from the street. And he was using the e-cigarettes that we gave him. And he also said that he didn't cough anymore as much, and he used to cough pretty much every day. Another chap who was from Ghana said he would always feel embarrassed and ashamed about smoking discarded cigarettes, and he doesn't have that shame anymore because he had the vapes. And for the hotel staff, what they said was what mattered most was that their clients weren't stigmatized because of their smoking behaviors. And when they reflected on their clients smoking discarded cigarettes, one member of staff said those types of things often get used to discriminate people. And actually, all that person's trying to do is manage a fairly difficult addiction without any money. And that's the reality. It's a cost and it's a practical decision. And he said, do you really think someone actively wants to be doing that? They're doing it because they really, really want a cigarette and they don't have any money. And few staff also said that their clients were consistently using the vapes, and a number of them had managed to stop smoking. And they said that's a huge deal, because this doesn't happen. And it should be celebrated. So what we have this problematic situation, and it applies to people experiencing homelessness, but it can be applied to other populations, such as those in mental health and substance use services. The greater the health and social care needs, the lower people's ability to change is perceived. And they need to stop smoking is seen as less of a priority, and so their opportunities to change becomes much narrower. And as we've seen from the research I've just shown, that people who experience homelessness, they want to quit and they can reduce their smoking when they're given the opportunity to do so. So just a couple of more studies that are actually ongoing at the moment I wanted to let you know about. The first one is an MRC funded study for developing a co-designed tobacco harm reduction toolkit for use in the homeless sector. And what we're doing is using an experience-based co-design method. So we're currently running focus groups with staff and service users in homeless services. And then what we plan to do is get staff and service users and some stakeholders together to run some co-design workshops. So we'll develop the toolkit, and then we're going to pilot the toolkit in one service. And the toolkit will be either electronic or a hard copy. And the type of things that might be in the toolkit, depending on what people have told us so far, is staff are saying they want to know how to write a compassionate smoke-free policy. So we provide templates for them. They want some conversation guides of how to raise the issue of smoking without annoying people. We'll add some guidance on evidence-based treatments and some problem-solving tips. They want some samples of NRT and e-cigarettes, and then we'll include some service user testimonials and tips. And for anybody on the call who wants to get involved in this particular project, we're still running online and in-person focus groups with staff who are working in the homeless sector and people who use those services. But any stakeholder who has a role to play in shaping homeless services would be really good to speak to. The groups last about an hour, and the focus of the groups are about people's understanding of tobacco harm reduction, people's experience as a good and not so good tobacco harm reduction across the homeless sector, and what you want to see in the toolkit. So anyone who's interested in taking part can email me or Sharon. And another trial that's just kicked off. So this is the step up from our feasibility study. And this is a randomized controlled trial within homeless services, and it's called Sketch, and lots of universities are involved in this. And it's led by London South Bank University and UCL. And what we're doing, we're trying to recruit 32 homeless centres in Scotland, England and Wales, and 16 of them will be randomised to get standard care, which is the gold standard support for smoking cessation, which is very brief advice and signposting people to local stop smoking services where they can get nicotine replacement therapy and behavioural support. And we're comparing that with 16 centres who are randomised for staff to give clients an e-cigarette starter kit and a supply of e-liquid. And then we'll be measuring how many clients in each of the arms of the intervention stop or reduce their smoking at 4, 12 and 24 weeks later, and whether they change their smoking practices, and the cost of effectiveness of the interventions, as well as the experience of the interventions. And we'll be recruiting 15 to 18 clients per centre. And this study involves, so whether you're randomised to standard care or an e-cigarette intervention, and it's the centres that are randomised, not the people within the centres. The service gets visited by a local researcher when they express an interest. We provide the centres with 2 hours on-site training. And then once staff have had the training, the researchers come in, they conduct baseline interviews and take informed consent from service users. And then if they're in the standard care intervention, the staff and researchers give out a leaflet and signpost people to the local stop smoking service. If they're in the e-cigarette intervention arm, then staff and researchers give out the e-cigarette starter kit, 5 bottles of e-liquid, and explain how to use it. And then what staff do, what centre staff do over the next 3 weeks is just give people the top-up supplies of e-liquids. And then researchers come back at 4, 12 and 24 weeks and do some follow-up interviews. Again, if you want to get involved in that, then we've got publicity material that I can send to Karen and she can distribute to send out to people, your contacts in day and residential services. And if you're a provider of a homeless service and want to discuss taking part, then again, we can send you information for you to contact and have a conversation with the trial manager, Kirsty Saw. And then the final thing I wanted to flag, OHID has commissioned the National Centre for Smoking Cessation Training to produce very brief advice online training for staff who work with people who experience homelessness. And I've just had a preview of the training, and it starts with a film of people in a homeless service in Leicester, and it's one of the best films I've seen in smoking cessation. It's very poignant. And then you've got me and Sharon talking about how to deliver advice across the homeless sector. So again, this is something we can send out to your networks when it goes live. So that's me. Thank you very much for listening to the whistle stop tour of what we do in this space, and happy to answer any questions. That's Sharon and mine's emails. And Karen said she'll send out the presentation and any study information that we've got. So thank you very much.
Thank you so much, Debbie. Such a lot of information in there, and the data and the disproportionate impacts that never fail to land. Can I open it up to the floor for discussion points, comments, questions? I know there was a lot of content there to digest, but I'm sure there's a lot of thoughts from our audience, many of whom are working in this space. Karen.
I've got one, Debbie. Thank you, Tracy. Was just to say, can you just explain a little more about the compassionate smoking policy? I thought that was quite interesting. What's what have staff said? What are their anxieties about trying to get it right so it's meaningful, but yet takes on board people's concerns? Because I think it might have use in other settings.
Yeah, so it's something that we've worked on in our local mental health services in SLAM since we went smoke-free in 2014. And it's about not just introducing smoke-free policies that prohibit smoking. And so all your conversations just become about, sorry, but you can't smoke here. But it's about making sure staff are skilled enough to have those conversations and making sure alternatives to smoking are available so that you can tell people what they can do rather than what they can't do. So starting conversations with, did you know that, reducing smoking is one of the best things you can do for your health and well-being, and this is how I can help you with it. We can link you up with people who can give you a nicotine replacement therapy or e-cigarettes or behavioural support. So approaching it from that way rather than, sorry, but you can't smoke here.
Thanks, Karen. Dave, did I see your hand go up and back down again?
Oh yes, thank you. Yeah, thanks for your presentation. Yeah, I think something that we've been doing at the Seaview project in St Leonard's is lung cancer awareness campaign recently, and yeah, I think this could kind of link in really well with that, because it's having those kind of sensitive conversations that without wanting to kind of shock people or scare people, but just sort of gently, raising the subject of health and obviously, trying to prevent cancer, then, this would be I think a really, some really good conversations to have. And yeah, I think definitely it's all about how to broach these conversations, isn't it? To make it, accessible for our service users, really. And yeah, really, great piece of work. We'd like to get, to be involved in that. Yeah, it sounds really positive. Thank you.
Thank you, Dave. And it's great to see that, those links are already being made into how it can support programmes and projects that are already underway, which is great. Jane.
Hi, Debbie. Yeah, I was just wondering as well if you've had any contact with Dental Aid, because I was thinking they talked about when they're providing dental care, so they have mobile vans that go around to some of the homelessness centres, and they were talking to me as well the increase of incidence of people with throat and tongue cancer. So I was just thinking there's obviously that link there as well to be talking to people about smoking and alternatives.
I think, yeah, that sounds like a great thing to do. It's not something we've not linked with them before, but it's something we do as kind of part of the smoking work. We do talk to people about their oral health and how smoking contributes, to poor oral health. So yeah, and we've linked up with Al Story, who does some brilliant work up in University College Hospital and his mobile TB service. But I quite like the sound of a mobile dental service as well. So thank you.
Great. And there is a question from Amanda in the chat, Debbie, around she did miss part of the presentation due to Wi-Fi, so we'll make sure those slides get circulated. But she was asking about the support for staff to stop smoking also, and the education as to why they shouldn't be accompanying users to smoke. Oh, you've fallen onto mute, Debbie. Don't know why.
Sorry, I obviously pressed something. So we give staff in the sketch study, so the randomized control trial, we give staff in homeless centres a 2-hour training session, and it starts with kind of making the case why smoking is so addictive and deadly in this population, and rather than kind of facing it head on, that it's really not that the smoking with clients kind of leads to this assumption that this is tacit approval for smoking if you're smoking together, and it's something we've talked about in the National Centre for Smoking Cessation training online course as well. We discuss why it might not be a good idea to do that. So yeah, it's something we address in the sketch trial and the training. Was there another? Sorry, for some reason I can't access the chat.
Just more general question about whether there is support for staff to stop smoking as well.
Yeah, so what we did in the feasibility study, our first centre was in Northampton, the Hope Centre, and what we ended up doing was giving staff who smoked e-cigarettes, because once a lot of staff have the training, a lot of them, a lot of the staff in the homeless centres then go on to make their own quit attempts, and either book themselves in with a local stop smoking service or go out and buy an e-cigarette. And it's certainly something that I would encourage as well. So I did some work, and it was a presentation I give to, again, Karen organised last week around integrating tobacco harm reduction in drug and alcohol services, and I talked about a piece of work we'd done in our drug and alcohol service in Brixton to integrate a tobacco treatment clinic, but I also ran a tobacco harm reduction group for staff there and gave them e-cigarettes. So what the clients were getting was exactly the same as what the staff were getting. So the potentially they were kind of in this, kind of created this impression that, you know, we're all in this together, and you know, we're all trying to stop smoking at the same time, and we've all got equal access to the same products and same support. So it's something I would definitely encourage to try and do. We were doing some work in Hounslow the other week for the co-design toolkit, and the clients we were talking to there said, well, I don't know how it would work here, because every member of staff smokes. So how are you gonna try and help us stop smoking when, you know, 9 members of staff smoke? So it is something that needs to be addressed.
Great examples. Well, thanks, Dave. Dave's put into the chat there about Dente to come along to the CV project there, which is great. So that oral health work's already underway in some places, which is really good to see. Karen.
I'm just going to make an observation. So what people may not realise, I'm just having a look at the attendance today, and I can see quite a lot of my tobacco control colleagues from local authorities on the call, but I don't see many housing leads from the local authorities or many service providers. So Dave, thank you very much for coming today. But do you think that might be one of the issues that we have to tackle, is in order to get people to access this information, we've got a barrier already in place in getting that information to those staff that work in these settings if there's high smoking prevalence rates among them?
Yeah, I think so. So I put up a slide when I talked about the ambition to go smoke free by 2030. I put up the report by the All Parliamentary Group on Smoking and Health that ASH work with, and within that report it talks about the work housing need to do in terms of helping with reducing smoking prevalence. And I think there's some examples within that report, and I think hopefully we're hoping to see it in the new tobacco control plan, much more of a kind of spotlight on housing and the role they can play. And I think within that report there's a great example of a social housing project in Salford, I think, that gave residents e-cigarettes as a way to reduce harm from smoking. So there's pockets of kind of great practice going on around the country in social housing in particular. But it's something, if we are going to have to reduce smoke, you know, if we're going to achieve that 5% or less, then you know everyone has got to get involved in this. It just can't be health or local authorities or just tobacco control.
No, I think what it flags is that we need to do a bit more outreach work with our colleagues, fellow colleagues within local government and so on. So maybe it's something that the Tobacco Control Network can pick up and have a chat at our next meeting in how we look at doing this, because it's a shame otherwise, isn't it? Because once the information's there and the training's there, it seems to be pretty successful. It's just getting through the door in the first place, isn't it?
Yeah, absolutely.
We've got colleagues on the call from some local authorities who I know are doing outreach work with their local housing social providers. I can see a few on the line. I don't know whether they feel comfortable in speaking, but there is work there, but there's certainly more to be done. Thank you, Debbie.
Thanks, Karen. I think that's a really interesting observation. Obviously, your experience of knowing the group has helped identify that. One of the conversations that I've been having locally is in terms of the general population. Is the general population, in terms of being available for us to work with smoking cessation, vanishingly small, and does it still need the same level of energy? Which, you know, is a really strange, as a public health person, a really odd conversation to be drawn into. But if people that aren't in the public health world and not in the smoking cessation world, if that is where their thinking's going, how do we motivate that conversation to help, you know, them realise that actually this is still an incredibly important issue and still one of the greatest drivers we have for premature death amongst our communities?
I think that's a really good point, Tracy. And I think it's something that stop smoking services have to, I think, adapt to those smokers who are left, or who we've left behind historically. So perhaps it's probably a bit controversial, but they need to think, you know, about their models, and their model kind of historically is an abstinence-based model, which has put off a lot of people with mental health problems, substance use problems across the homeless sector. You know, if they rock up a stop smoking service, are they going to be expected to stop completely within 2 weeks? And so I think a lot more flexibility and probably a lot more upskilling of stop smoking practitioners to work with people with more challenging and complex needs is needed. And it's also good to see that. So ASH do an annual survey of the tobacco leads in local authorities. And in 2011, the tobacco lead said that 11% of stop smoking services were providing e-cigarettes as part of their support offer. And then last year that had gone up to 40%. So I think as stop smoking services become more e-cigarette friendly, but they also get some funding from their commissioners to provide e-cigarettes, then that will attract a new type of smoker as well, I think.
Thank you. Helen, I think I talked across your hand. I apologise. Do you have a question or a comment?
No, sorry, I was just the previous conversation reflecting about our work with homeless through the pandemic, and we stepped in to support, which was effectively risk management, because they were homed in a hotel. So the risk there was about preventing smoking in the building. But
It's not something that I felt the staff around them supporting them were overly interested in, didn't see it as a priority, saw they had a huge other agenda to be dealing with in supporting that client. And it's, this, in services like that, this has to be very much driven down before you can attempt to embed that into kind of normal support and practice.
Yeah, I agree. And at the beginning of the pandemic, when we were delivering e-cigarettes, we were literally kind of loading up our cars and going into hotels that were just literally being set up. And I have to say, most hotels are really receptive with a couple of strangers, that they'd never met, with boxes of e-cigarettes, and having to engage them really quickly in a conversation about why they needed these e-cigarettes for their clients and how to distribute them. And I have to say, kind of in London, the fact that we still get requests for e-cigarettes, and we must have distributed about 5,000 starter kits, which is incredible. And we purposefully didn't give them e-cigarettes or ask staff to do anything particularly other than give them out and give people a leaflet, because we knew that they all had other priorities. They all had to keep people safe from COVID, and they all had resettlement work to do. So largely the residents took charge of that themselves and taught themselves kind of how to use e-cigarettes. And what we found kind of from talking to staff was that once everything opened back up again, those people that could afford tobacco, they went straight back to tobacco. Those with no recourse to public funds continued to use the e-cigarettes rather than picking up discarded cigarettes or resorting to begging to pay for their cigarettes.
Any other questions or comments for Debbie when we've got her expertise with us? Amanda.
Yeah, hi, sorry. I just wondered if there was any studies that you came across in all of your looking that alluded to incentives with homeless clients. We know that it works in the world of pregnancy, but I'm not sure it's something, incentives by way of vouchers or others, to support homeless smokers. Has that been something you've ever come across?
It's not within homeless, certainly within kind of mental health and drug and alcohol services, but I've not seen it within the homeless population. So no, other than us giving people free cigarettes and free products, I've not seen it in kind of giving people money or vouchers. They may well be something. There might be something in. There's a recent Cochrane review of smoking in homelessness. It possibly might be something in that report.
Worth looking into, because it's quite a contentious debate, isn't it, right across the board in terms of incentivisation.
And very successful in pregnancy.
Yeah, it is interesting, isn't it, in terms of where it works. Yeah. My background's in sexual health, and I remember there being a lot of incentivisation around when the National Chlamydia Screening Programme first came out, about incentivising 15 to 24-year-olds, and ridiculous things in some local authorities, like prize draws for the wee console and badging that as a wee for a wee, and it drove me mad. So there is a lot of, I think there's a lot of contestation around the idea of incentivisation. So, but some places it does work well, others it does feel a little bit unethical.
Yeah, colleagues did some work again in the same centre in Brixton, where we give out free e-cigarettes, and they did a contingency management study with people who used heroin and financially incentivized them to give up smoking. But it didn't work out too well. And then when we went back kind of a year later to then embed an actual tobacco harm reduction service and gave people the choice of e-cigarettes and nicotine replacement therapy, that did much better than the contingency management.
Yeah, really interesting. Daniel.
Hello, I hope you can hear me because it's the IT's failing me quite miserably this afternoon.
Yeah.
I manage a street outreach team on behalf of a local authority in Canterbury, and it's interesting that we've really been encouraging staff to train as public health champions, and we've been doing a lot of smoking cessation courses, and we've been trying to kind of approach those conversations with service users. But it does strike me that actually everybody in provided the ample opportunity for us to be doing quite a lot of that work, because the circumstances meant that we basically, for a period of kind of 7, 8, 9 months, moved in with the clients that we support. But street outreach kind of models involve going out late at night, early in the morning, identifying people who are sleeping rough, trying to engage to provide urgent assistance. And even our most kind of comprehensive assessments sometimes feel very onerous when we're working with a particularly kind of complex client group. And I suppose that there's the motivation and the inclination for us to want to do more work, but I think what seems to be golden to me is finding the right time and the opportunity to do those interventions. And I think housing are often always in that difficult position that we're often trying to move faster than we can walk in terms of trying to get someone into safe accommodation, and then we're back out on the street again.
Yeah, I think exceptionally challenging. I think we were approached by people in Alcohol Change UK in Wales recently. They wanted to try and use e-cigarettes as part of their outreach work with very chaotic drinkers who are also homeless, and they seem to see a role of trying to use, so as well as kind of giving out clothes and food and hats and sunscreen to people on the streets, they wanted to try and give out e-cigarettes and then try and get people to come into services. So these are people who won't engage with services, come into services for their top up supplies for the e-cigarettes. And it's something that's just in the early stages. We want to try and get some funding to try and do some feasibility and exploratory work in that. But also, we're just about to start some peer interviews in Wales about, what my clients think about this type of intervention. Is it something that's just a step too far for them, or might it have legs? But certainly the people in Alcohol Change UK want to try and do something around smoking to people who are street homeless and in that chaotic period of drinking.
Thanks, Karen.
Just following on a couple of those points, I thought that was really interesting and really insightful, Daniel, in understanding what colleagues have to face, because I think that's sometimes, we start projects and initiatives and not really listen and hear to what our peer colleagues might have to face and try and work around in order to make that work. So I think it's really important we build relationships with you and your colleagues to get that understanding, but also, as you said, maximize on those golden opportunities where finding the right time. So what colleagues might not know from the tobacco control world might not appreciate is that there's been some incentivization around the uptake of vaccines, and there's been dedicated funding for trying to encourage those who are experiencing homelessness to have their COVID vaccines and so on. But that might be one of those opportunities where there's incentivization taking place for another public health strand, but being in the same place at the same time, and and using that opportunity to have that broader general health message. So, you know, it just shows the importance of that connectivity, isn't it? And the real strong value of partnership working. So, you know, when your other health colleagues are going to be out there with this client group, and maybe there are synergies in doing some outreach work with them at the same time.
Thanks, Karen. And I think that is something that has been talked about in, you know, certainly, like you say, around the booster vaccinations across the spring, to try and do that, you know, every contact counts stuff. And I think it's really difficult in terms of people recognising that as an opportunity. Like you say, you've got people pitching up, we've got them there, let's utilise it. And certainly where we're doing targeted interventions with certain population groups, why not maximise that opportunity in terms of those conversations and bringing people along with us, which is brilliant. Is there any other final questions or points that people would like to make? Huge thanks, Debbie, for coming along this afternoon. Obviously, your time this afternoon's been invaluable for having the conversation, but also the brilliant research that you've done that's informed the afternoon. We will make sure those slides come round, and obviously there is a lot there that you can then go away and have a read and further exploration on, and obviously other research projects that are currently underway. And a call for inclusion if you want to join in with those, which I'm sure many people will. So thank you, Debbie. Absolutely brilliant. Thank you so much.
Thank you. Thanks for the opportunity. And I'll send Karen the slides now. So thank you. Have a good afternoon.
Thank you.
Well.